Good evening. My name is Kent Dix, CEO of Life 365, and welcome to our 10th in a series of webinars related to COVID-19, telehealth, and remote patient monitoring. Before I introduce our panelists this evening, I want to take a minute and thank all the healthcare providers, first responders, family caregivers, home healthcare workers, child care providers, food and grocery delivery, transportation, healthcare manufacturers, and many others. Thank you sincerely for all you do. I also want to let you know that everyone will be on mute and that we will accept questions via chat and try to entertain a few questions throughout the webinar. We have reserved some time for questions at the end. If we don't get to your questions, we will answer them after the webinar and post them, the recorded video, on the life365.health website or www.newnormal.buzz tomorrow. Now I want to take a minute and introduce our distinguished panelists. Cynthia Ekberg Shai, CEO of HealthQuest. As CEO of HealthQuest, a global biotechnology and medical technologies advisory firm, Cynthia Shai specializes in providing strategic introductions and advice to rising executives. She believes the best business deals, strategies, and relationships develop in great settings. As a former New Yorker with 2 decades of experience as a Wall Street executive and a degree in psychology, she is an authority in the way in which the work setting can focus, nurture, and stifle innovative thinking and strategic ideas. Think of Cynthia as a personal GPS guiding you to the destination. Welcome, Cynthia.
Thank you, Kent.
Yeah. Dr. Robin Smith, founder and president of CURA Foundation. Dr. Smith is a business leader, entrepreneur, medical doctor, and a philanthropist, uniquely positioned to assist public companies and healthcare systems to advance and be successful in the rapidly evolving healthcare industry. A graduate from Yale School of Medicine and Wharton School of Business, Dr. Smith is a trailblazer in the fields of regenerative medicine and predictive analytics, and has focused on turnarounds, M&A, and disruptive innovation, driving interest and growth. Dr. Smith has co-authored 2 books, Cells Are the New Cure and The Healing Cell, and How the Greatest Revolution in Medical History is Changing Your Life. Dr. Smith is also active in many nonprofit organizations. She is the founder, president, and chairman of the board of the CURA Foundation and STEM for Life. Welcome, Dr. Smith.
Thank you for having me. Looking forward to the conversation.
And Joan Koerber-Walker, President, CEO of Arizona Bioindustry Association. As President and CEO of AzBio, the Arizona Bioindustry Association, Joan leads an organization that serves as the unified voice of the bioscience industry in Arizona. AzBio strives to make Arizona a place where bioscience organizations can grow and succeed. Welcome, Joan.
Thank you so much, Ken. It's great to be here and see everybody.
And thanks for having you as well. So I do this at the very beginning and throw some stats out. 3 weeks ago, we had 5.7 million people in the world that have been diagnosed with coronavirus. Today, we're at 8.4 million. An increase of almost 3 million people, or an increase of 30% in 3 weeks. The US has had 1.7 million 3 weeks ago that tested positive, and now we have tested positive, 1.7 million, and now we have 2.2 million. We have conducted 25 million tests in the US to date out of 330 million people, so about 8% of the population. We now have 120,000 deaths in the US, expected to go to, these are predictions, 200,000 by September-October timeframe, and potentially over 1 million into spring of 2021. So that's why we're having this conversation tonight. Arizona, Texas, and Florida, positive cases are on the rise, with ICU beds nearing capacity. So Joan, I want to go to you first and ask a simple question, and maybe it's not simple. Where are we going in Arizona with COVID-19 currently, and how are our life sciences and healthcare companies prepared to help in the current crisis?
So that's 2 very different questions.
Yep.
The first question is what's happening in Arizona. And for those of you that live in Arizona, you're hearing it on the nightly news. And now, as Arizona took its place as the #1 hotspot in the country, based on the growth of reported cases, Arizona is part of the national news. Robin and I had a chance to talk about this just a little bit before the call. And I think that in states like the Sun Belt states, Arizona, Texas, and some of the others, where we did not experience the rapid growth of COVID cases that we saw in Mid-Atlantic and New England. And because of that, it gave people perhaps a difficult ability to really perceive and understand. What you see on the news is different than what you know your neighbors are experiencing. And so whereas you would see a lot of safety precautions, masks, cleaning stations, constant reminders in places like New York, Connecticut, New Jersey, it was not as prevalent in Arizona. Now, as we're starting to see those cases come up, not only the government, but more importantly, the business community is becoming very, very vocal on the importance of wearing masks, properly preparing the workplace, proper sanitation, because we don't want to go backwards. So I think that kind of addresses where Arizona is. And we are very, very carefully monitoring not just our caseload, but also our ICU capacity, and have some emergency measures in place if, God forbid, we need them. But we're sincerely hoping that it's going to start stabilizing again now that we've gone through this uptake after Memorial Day.
So you're seeing no correlation between the virus and between temperature, between cold or hot, right? From that, whether it's warm states or whether it's cold states, right? From that.
I mean, and I think that what we saw in Singapore earlier on was a pretty good indication. You know, there had been a lot of conversations about, oh, well, you know, when it starts to get hot, the virus is going to go away. And, but what we saw is in the Southern Hemisphere, where in the wintertime, it is hot.
Right.
They had an escalation of cases. So that was one of the contributing factors, I think, that to you know, scientists not expecting that to really happen. I think the other thing that is significant is in places like Arizona, where when it's really hot, we tend to congregate inside. So we go to movie theaters, we go to shopping malls, we go to stores. And so people that are going to that air-conditioned environment, that makes it no different than any place else in the world.
Right, makes sense. So Cynthia, I mean, by very definition, I think Montana, where you're at tonight, is probably considered social distancing in itself, right? Just by the mere amount of people and land space that you have out there. And we haven't seen a lot of outbreaks in Montana from that, if I've read the stats correctly. How is, you know, COVID-19, and how are you coping with COVID-19 in Montana right now?
Well, I think Montana has been blessed, and this is a good time to be the last on the list. From my perspective, it's a state that people still want to enjoy outdoor recreation, and they are fishing, and they are hiking, still paying attention to wearing masks when they are in a bakery or they're in a grocery store. But still a lot of opportunity to interact with neighbors, that we just have been very fortunate that very few people have tested positive, and very, very few number of deaths. But, you know, since the 1800s, Montana has had social distancing.
Yeah. So are they actively testing in Montana? If you want to test, can you get a test in Montana?
Absolutely. And we have friends that are part of the hospital network, and they've done a very outstanding job of being prepared because we are a rural state. And so we have to depend on those opportunities. Now, if you have to go to the emergency room, you may go, you're not allowed to really go with someone else into the room with you or into the hospital with you. So that screening has still been very thoughtful. We had to take one of our neighbors that got hurt on his ranch to the emergency room, but we did not go in. We just waited for him and then picked him up. But Montana's been very thoughtful about being prepared and still paying attention to COVID.
Right. So, Robin, if I can call you Robin, yeah, I want to go to you really quickly. It's good. I mean, we've got a really eclectic kind of group here from various parts of the United States, which is great. Rural and Southwest, and you're from New York City. From that, you just went through a massive experiment in New York City, and you're still doing that as well. How was New York City being part of, the first wave that's there? How did people shelter in place? Because it's, for all means, it seems like you guys have done a great job in getting it under control.
Yeah, I think many people are working from home, not taking public transportation. Stores are still closed, hair salons, nail salons. We're really in the first wave of opening where it's really the essential workers. So there was a real shutdown here. And I think that people did a pretty good job of isolating themselves, being cautious. Rules were set in place, a certain number of people. If you went to a Target, you only could go a few at a time, and you had to have the 6 feet apart from one another. So I think in New York, they did a pretty good job of getting this under control. But one thing I think is critical as we talk about numbers increasing, COVID is here and it's with us. And I think there were a lot more cases and a lot more people have it. They just didn't show symptoms. The more you test, the more cases you're going to find. And obviously, when you start relaxing the social distancing, there will be more cases. And the scary part is really the people who, before they get symptoms, are at the highest ability to transmit the disease. And we really have to protect those that are more at risk. And, those that have other comorbid conditions who will have more severe cases of COVID if they get it, as opposed to having their immune system easily fight it and moving on.
Yeah, it's interesting. There was conversations I've even had as early as this morning, about building programs of safely going back to work, to be able to do that. And part of it was, testing people, at least up front for the AB test, for the antibody test, as one of the first courses, just to make sure if you have the IgG and you have the antibody that's there, then you may be safe to go back to work from that perspective. And then the next group is you're not showing signs, but you want to be tested, with antibody tests just to make sure that you don't have the IgG, but you don't show symptoms. The next one, you show symptoms, but then you do maybe the nasopharyngeal, PCR test to test them. So there's people that have got things set in place to be able to go through and try to get, get people tested to get them back to work safely as well. I went personally this morning and went to Snoring Quest. They just started offering it this week and got an AB test. So I'm interested to see, what it's like for the next, in the next 2 or 3 days. Because a lot of us were sick in the winter and early spring, and it may have been corona. We just don't know, right, from that. So it's good to be tested to see. It's the first step to going back to work anyway, right? I think safely.
And I think it's important to remember,
go ahead,
if you have the antibodies, it doesn't mean you're, not necessarily going to get the virus if infected again. People have gotten reinfected. Maybe your case will be less severe, but you still should wear masks and, still should be cautious.
Yeah, and go ahead, Joan.
So it's interesting. I had a call yesterday with a number of large national employers, and we were discussing their reopening strategies. And they're still trying to figure this out, just like all of us are. And so one of the things that I shared with them was that the antibody test, assuming you have one with a reasonable level of sensitivity and accuracy, is a good way to establish a baseline for your workforce, to try and figure out how close you're getting to that magic number once we understand if this disease will even generate a herd immunity. And so, but if you establish a baseline, you can at least identify people that have had the disease before. So you have that one subset. Then you look at, as far as testing using PCR, that's to determine if the virus is active in an individual at a given time. And so that's what you're going to use if somebody has health concerns, if someone is exhibiting symptoms. But basically everybody, as Robin said, everybody has the potential to transmit, whether they've had this disease before or not. And so the mask that I wear protects you, and the mask that you wear protects me. And to be socially responsible, we all need to wear them in a public setting.
Right. No, I want to go back to, no, I love that. We talked about that earlier as well. I mean, I put down the mask up AZ as well. I really do believe that we should be wearing masks, but Joan, you and I talked about this a little bit. I don't have the same experience as you. When I do go out in the morning, I'll go get my Starbucks, right? Or whatever, my wife's Starbucks. I will wear a mask going through the drive-through. I see probably 90% of the people around that aren't wearing masks. I just do. Whether they're in their car, I understand. The workers are wearing it. But the people that are waiting outside the door to get in, to get their drink and stuff, they're 2 or 3 feet apart from each other and they're not wearing masks. And I don't get it right from that.
It's the complacency issue. We have, New York City is a highly densely populated area. And so, a lot of the spread and the tragedy that occurred in New York was driven by density. Here in Arizona, we don't have the density. And so people did not see the rapid escalation of cases. And so logically, they may know that they're supposed to be more careful, but psychologically they're saying, but I don't see the risk. And I think it affects behavior. Robin, I'd love your take on that.
Yeah, I think there's a part, every generation's a little different. I think sort of the youth, they're just invincible, and they're just so, they've missed out, whether it's graduations or, all of things that they look forward to. And it's hard for them, to really sort of get their hands around what that is and how severe this really can be. So I think there's this sort of, I haven't had it, I've been sequestered and I just have to get out and it'll be fine. And that's challenging because it's not so much about that person, but it's about who they would expose, their parents, their grandparents. And the fact that the kids aren't really, or at least getting as sick, we're not really thinking about spreading. So, I think in general, it's very important. There needs to be a little more empathy, sympathy, compassion for others, and recognizing wearing the mask isn't necessarily about yourself, but it's about someone else. And that's really important. You have to unite to prevent this and to protect other people. And I think right now that's being lost a little bit in people's just desire to get out and start getting back to normal. So
I think also people are actually worried about, they've lost their jobs, they've lost their businesses, they're financially strapped from that or actually over the brink. And they don't know if the information's accurate or not accurate, if it's political or not political, motivated from that standpoint, and they're tired of it a little bit from that as well. But the people that are wearing masks, I wish that we could come to as a country, if you do choose to wear a mask, it's there a lot of times to protect you, not me. And you also don't know my health conditions as well, right, from that. So we should all try to, I know it's easier said than done, get along, right, from that as well. Cynthia, I want to go back to you in just a second, but Robin, I want to go back to something you said about the antibody test, that it's not foolproof as far, well, I know the accuracy, there's a question about the accuracy versus the PCR test or the false negatives. But if you're going through and doing an antibody test, that doesn't give you the assurance that you can't spread. It doesn't give the assurance that you can be reinfected from that. Can you talk a little bit more about that?
Yeah, I think in this case for the antibodies, you don't worry about false negatives, because if you get a test that says, I don't have it, even if you have it, that's a benefit. What you worry about are the false positives, the ones where you think you have immunity and you really don't. So that's where I think there's usually it's 4, 5, or 6% based on all the tests that are out there. And those are the ones that are sort of credible tests that have been given emergency use authorization. That you just have to be careful of, because it's sort of false sense of security. But, there have been people who have had COVID and have been reinfected. And, we're learning more and more as time goes on what that means. Are there certain risk groups? And if you do get reinfected, is it as severe? Are you contagious? So, there's the data around this just continues to unfold. And there still is a level of uncertainty as to what this all means. Are there different variants, different mutations? And so really the key is going to be the vaccines, and that will really help us get more immunity, herd immunity, and help our immune systems fight the sickness or the illness or the virus when we are exposed.
Yeah, that's great. So Joan, did you want to say something?
Well, Robin, I'm just curious. I know one of the things that we've also been looking at is with mild cases, we don't have titer levels established for this disease yet. And for those of you listening that don't know, so your titer level would determine if you have what's considered the safe level of antibodies for immunity. But we've also seen with some of these viruses that people who've had mild cases or even undiagnosed mild cases, when we go to vaccinate, it actually has the opposite effect and creates a very adverse reaction that can put people at risk. So as we're talking about vaccine development, and which is that holy grail that we're trying to get to, I think that one of the reasons that we have to be very careful on developing the vaccines is we need to understand, and we will use the antibody tests to some extent to help us understand how people who've had the disease, but perhaps we didn't know they had the disease, how they might respond to vaccination before we start doing broad-scale population vaccination.
And certainly the type of vaccine will make a difference with respect to that. I agree. And even if you have immunity, we don't know how long it will last. So you could have immunity today and 3 months from now it can be gone, or 6 months, we don't know. Not enough time has passed. So there's still a lot more information that we need to collect, and I'm sure the thinking around this will continue to change.
Yeah. So Cynthia, I know you're all about innovation, right, and life science as well. What are you seeing out there that's incredibly innovative that is being worked on for coronavirus, for COVID-19, or in general towards better quality of life for us going forward with this disease?
Well, thank you for asking that question, because when there are crises, there's still thinking and creativity that goes on. Some of it is focused specifically on that, but sometimes it gives people a chance to put everything on pause and actually spend some time in the innovation of solutions. I'm seeing some very interesting technologies from innovators who have worked in trauma, translating that to the real needs now. So new catheters that could make a difference for a stroke patient. And there hasn't been anything novel in stroke for a long time. One of the other things that COVID has taught us is your general health matters. We really need to think about the importance of just being in good general health. And I think that there's going to be a lot more focus on nutraceuticals, ketones, things that allow us to keep our own immunity strong. And I've seen a number of my friends on Facebook that are doing more for their own personal health. And I think the innovators are taking advantage of some of that too, Kent. I'm really interested in a number of companies that also, while they might have been going the direction of maybe a cancer therapeutic, are seeing opportunities to move that into COVID.
Right. It's interesting how people are now starting, because they need to, because some of the new normal, they're starting to blend some of the digital health technology, the telehealth technology into the life science technology and creating new opportunities like oncology, right, from that as well. I mean, to be able to teledentistry is another one, right, that's out there, but tele-oncology, telepediatrics, right, as well, for people that just can't get to a doctor or need to be able to go through their therapy or continue their therapy, but do it remotely, right, from that, because they can't afford to have them stop, their therapy midway through because they can't get into a healthcare facility. And the same thing goes true for clinical trials as well, right, with that.
So clinical trials is a real good example because COVID has created a disruption in the current clinical trials structure in multiple ways. On one side, we have patients that are at-risk patients who were not stopped participating in their clinical trials because they couldn't get to the hospitals or they were in fear of going to the hospitals. In other settings, the inability for these patients and their caregivers to take them in to meet with the clinical trials team for monitoring. That's where telehealth has really stepped up as a savior for some of these clinical trials. We have to keep in mind that when COVID appeared, these other diseases did not go away. And so we really, as we start looking at how we reshape, how we look at the discovery, development, and delivery of medicine, we really have to keep in mind that COVID and cancer are not mutually exclusive.
Right.
COVID and MS are not mutually exclusive. COVID and heart disease are definitely not mutually exclusive. So we have to keep doing that. And I am so proud of so many innovators here in Arizona and across the country and around the world that have found innovative ways to keep their clinical trials going, keep their patient care going, and not leaving those patients in the lurch when they desperately need our help. And many of them felt, as the conversation on COVID escalated, that we had forgotten about them.
Right. Yeah, it makes sense. It's interesting. I am all about data. I mean, obviously, I'm all about patient engagement and quality of care and satisfaction. But the interesting things that are coming in now out about our new connected world and how valuable data is. Data is not just about running through AI and trying to help just with the chronic care and diseases and giving access to care. Data actually can be very, very instrumental in trying to see some of these trends starting to occur. I mean, one example I probably give about every single webinar is talking about the company Kenza. Kenza, that's out of the Bay Area, is a simple thermometer company, and they are trying to predict the flu, right? So they have over 1 million data points that's out there. But when this started coming around, they tried to get the attention of the CDC, and the CDC's model was to go through and get data from doctors and hospitals, and it could take 3 or 4 weeks to be able to see that trend coming. With Kenza and the data analytics they're doing, they actually now can see the trend occurring. In fact, I think it was on MSNBC, they showed it 6 weeks ago, showed Florida was on fire, right? And New York was amber, right? And Washington was amber, right? From that, and New Orleans was a little bit on fire. But we started seeing these models starting to occur because we're getting the data real time. And the work that we're doing with one of the largest tech companies in the world, and they're taking in 250 data points, temperature is just one of them, right? That's that, right? ICU filling up and beds filling up, right? And other things that are data points, whether it's from us for, SpO2 or for, pulse oximetry or blood pressure, all those are data points to try to help us in the future understanding where this is going, right? From that. I want to, go ahead, Joan.
Well, the other thing I think that's really interesting as you talk about that, Ken, is the work that's being done right now with wastewater. Because we know that the virus at least throws off in human excrement. And so the wastewater that goes into the sewer system is now being analyzed. And the interesting thing is you can tap into that at the outside of the factory and see if the viral load is going up or down in the water. And if it's detectable and significant enough, then that's a trigger to tell you, go give all your people PCR tests. Yeah. And we're looking at, that's being done right now Companies are looking at doing it at the large plant level. Cities and towns are already starting to do it at the municipal level. And I think we're going to get some very interesting data points from that.
Right. Joan, there's a question that's being asked by one of the participants about what are we doing for Native Americans, right, or the American Indians, right, especially here in Arizona.
So what we've seen, especially on the Navajo Nation, is truly a national tragedy. Now the combination, and for those of you that are not familiar, the Navajo Nation is extremely large in size, but it is not dense in population. And so the healthcare resources, the healthcare facilities are limited and pretty spread out. In addition to that, the ICU, the concentrated ICUs are outside of the nation in many cases. So you would see, for instance, in Arizona, 3 different counties are coming together to support that healthcare. When we look at the nation, one of the things that we think, we don't know, right? There's a lot we don't know. But one of the things that we think could have been a flashpoint was the grocery stores, because that's one of the places where, it's congregated setting where people were coming from all of these different rural points to a single point. So we think that the grocery store was a primary instigator on spread, but we don't know that. Hindsight's 2020. The other thing that we look at is the public health. While Indian Health Services, which is the federal government, is responsible for supporting all of the nations, and here in Arizona, we actually have 21 tribes, so 20 plus Navajo. And so Indian Health has the ultimate responsibility for that until they leave reservation, until they leave their Indian country location, and that's the correct technical term, and moves to, the city of Flagstaff, for instance, or go to Albuquerque for care. And so in that case, we have seen the federal government step up with supplies. Now, one of the things that's a real challenge on the Navajo Nation and other very highly rural settings is to go and take samples for PCR tests, and then the delay of going back and forth just doesn't work. So the rapid tests, setting up mobile test labs on native land, all of those things are being done. It was not done fast enough. The other thing that we do know is, and unfortunately this is common not just with the Navajo Nation, but across Indian country, is that there are high levels of comorbidities. So there are high levels of behavioral health problems, there are high levels of heart disease, there are high levels of diabetes. These have all been identified as, and COPD, so all identified as high risk individuals. So when COVID started spreading across that community, it became a bigger issue. Education is much harder to get the word out on the Navajo Nation, and I specifically to the Navajo. President Nez has done a phenomenal job of communicating with his people on, the importance of wearing a mask, the importance of sanitation. But they have limited resources, and there are some people living on the reservation, either by circumstance or by choice, who don't have the standard things that we take for granted, like running water, electricity, etc. And so that also complicated the ability to address some of the care issues.
Okay, so that's great. So Dr. Smith, I wanted to ask you a question really quickly about, the phrase has been out there, and this kind of ties to what you were saying, Joan. If you want a test, you can get a test. But the thing that I personally experienced, and I know others have experienced, is that, on the AB test, the antibody test, I can walk in, pay $99 myself, right, and get an AB test if I want to, right? Maybe not a lot of people can afford that, to do that. On the nasopharyngeal test, right, a PCR test, that has to be signed off by a physician or a PA. And I found that a lot of, even when I personally went, because I wanted to know about it 2 weeks ago, 3 weeks ago, I was assured that anybody could get a test, but I still had to present with symptoms. I still had to, for the insurance companies to pay, or for my insurance company to pay, I had to present with a symptom. Basically, urgent care is saying anybody can be tested because it can show up with people that are asymptomatic from that as well, but they were still requiring me to have symptoms, right, to do that. Are we getting better with that, Dr. Smith, or do we have to go in and make up symptoms to be able to get tested for this? I'm not admitting anything to my insurance company from that. I had real symptoms. But what's your thinking on testing?
I mean, I think that, it's a really good point. The problem is that we don't have enough resources. And I think we have, it's a little more lax. I believe now you can go to the pharmacy and if you have symptoms, you can order. The problem is, even if you don't, every week you'd want to go and get tested because if you don't have symptoms. So where does that stop? And so I think they have to make sure that we can at least test those that do have symptoms. But the scary part about it is the fact that, it's a week before you actually have symptoms that you're at highest risk for spreading it. So that's problematic.
Right. Yeah. So it's interesting. I, like I said, when I went and got tested, one of the people that we're working with as far as a company, and they're doing that go back to work safely, they're a lab, and their large employer, one of the large employers they're working with, is the idea is potentially to put an app on the phone that if the app is green, you've been tested that week, and you're safe, right, to be able to go back to work. If it's red, you haven't been tested.
But are you safe? I mean,
I know.
Just because I was done on a Monday doesn't mean I wasn't exposed on Tuesday or Wednesday or Thursday or Friday. So, I mean, I think do you have the virus is really more of a, if you're sick and they want to find out what's wrong with you, do you have the virus, as opposed to prophylactic? Because otherwise, then really you should get tested every day.
So what do you do letting people go back to work, right, from that? I mean, should they only let people go back to work that are symptomatic? Right, or not, they're asymptomatic, right, from that, or keep people out of work or do you antibody test them every day, right, from them?
But even if you get it, usually you don't get antibodies for 10 days to 2 weeks, so you wouldn't necessarily have antibodies. I think masks, right, social distancing, masks, washing your hands, and all the things that we've talked about today are the best way of not just protecting yourself, but protecting others.
And Kent, you had asked me once before about what have we learned from past pandemics.
Yep.
And the one thing that epidemiology has shown through every epidemic, is that sanitation, distance, and common sense are the best ways to prevent the spread of any disease until you have a vaccine. And so when we look back on this time, what we're reinforcing is what we learned during the plague. It's what we learned during the flu pandemics. It's what we've learned during the polio epidemic, which is until you have a vaccine, until you can create herd immunity, distance, sanitation, and common sense, responsible behaviors are the only things you can do to limit the spread.
Makes sense. Makes sense. Cynthia, I want to ask you a question about the Galleon Foundation, and the work they're doing around healthcare. Obviously, I assume you've been very active, and I think Dr. Smith, you as well, right, from that. But can you explain to me a little bit about their purpose and mission in life?
Well, absolutely. Just have to give a lot of credit to Bruno Cohen, who's the innovator to bring the Galleon Foundation to the U.S. and to recognize great accomplishments in the sciences that go beyond just discovery of a molecule. These are technologies that are actually in the marketplace. And it's kind of the pre-Nobel Prize thinking and kind of the Davos of science, as Bruno likes to say. But, it has been an ongoing opportunity to bring science and business together. The annual event in New York will be in October, and Joan participated as well as Robin. Robin has also been a sponsor of the Galleon Prize, but it really recognizes the innovators of our day. And every other year, there's recognition of people from the foundation world that have provided so much. So Doctors Without Borders, for the work they did in Ebola, the Gates Foundation, obviously, for so many of the things that they have done. We've honored a number of executives, including Dr. Roy Vagelos for the efforts that he made to stop river blindness. So it's a very significant event. It's a day-long event in New York, first to meet with experts, and then capped off that evening with a gala at the Natural History Museum. And Bruno has also brought international recognition, and the Galleon now travels throughout the world to honor even the science in Senegal and Monte Carlo. So it's a really significant spotlight on the things that change our life and bring value to people.
I assume this year is going to be a really tough year because of all the innovations that are going on around the virus and around vaccines as well, right, with that. Dr. Smith, I wanted to ask you a question about vaccines because I want to understand them better from that. There are different types of prophylactics or vaccines that are being made available for the coronavirus. There's ones from an angle of it totally tries to eradicate, and I'm going to get this wrong, eradicate the virus, from your body by using your own white cells or your own immune system. There's other ones that try to wrap around the virus and not make it so toxic or fatal to the body, right, from that. I wonder if you can go through some of the variations of some of the viruses or things that could actually stop the spread of the virus that people are working on.
Sure. I mean, I think it's both from a therapeutic perspective as well as from a vaccine perspective. So, Cynthia talked a little bit about making your immune system healthier and, being able to fight off, viruses and other illnesses. But I think what we're learning is the cells of the immune system, whether it's taking antibodies from someone's plasma who's been exposed to the virus, NK cells, stem cells. There's like over 100 clinical trials looking at how we can take these cells from someone else's immune system and give it to patients to either be a therapeutic when they've been exposed or as a vaccine, so that when your body sees the vaccine, you can either create an immune response that grabs onto the virus at the spike protein. There's all different ways people are trying to approach this using what we've learned from the past. And, I think there are 5 candidates right now that that have been selected to really expedite what they're doing, in the development and in the manufacturing. But there's others that have found antigens that appear to neutralize the virus altogether, that by making a cocktail of a few different ones, if there's a mutation or otherwise, that you can shield. Sorrento is looking at the COVID shield as a way to actually, help the body have a shield if you get exposed to the virus. And so, there are definitely different ways that people are looking at this based on what they've done for, the regular flu, the H1N1 vaccine, and other things that they've learned in the technology, whether it's the mRNA like Moderna. And so I think they're moving very quickly. We're seeing some very positive results. It's accelerating, and I think there'll be a lot more to come. And that, to me, will really sort of give you a breath of fresh air, just like we have with the regular flu. I mean, flu is with us, and every year people get the flu, and we're able to immunize the elderly and other people at risk to prevent the flu, or if you get it, to get a less severe flu. And so the key will be, can you help, say, an older person, the ability to make their immune system fight the disease through immunization? And we just don't know. This is a very aggressive virus.
Go ahead.
One of the things that's really interesting about flu right now, because there's been a lot of talk about the risks of the hospitals with the combination of flu season and corona reestablishing in the fall, not because the virus went away and came back. It's always here, but we start congregating more. People come together more in the fall because of school. And so one of the things that is very interesting is an initiative that's being led right now and being developed by Grand Canyon University, which has students all over the United States, which is to really focus on flu inoculation during as soon as the flu vaccine, we don't even have the flu vaccine yet for this year. But as soon as that flu vaccine is available, really putting a huge focus on getting as many people vaccinated for flu as possible while we're waiting for the vaccine for COVID-19. And that way we can reduce the incidence of other diseases and other disease complications, because what we don't want to see is a patient that has COVID and the flu at the same time.
Right, right. It's interesting. I've seen companies working on multi-test right now to actually go through. I think there's one out of Ireland that's working, that's coming in the US right now, that not only looks for the virus, but also goes through and looks for flu A, flu B, RSV, others as well. So that was one of the biggest things when I went to urgent care. They said they were testing the heck out of people in January and everybody was negative for flu. They're just giving them flu tests. But if they had the multi-test that was out there, a multi-assay, they could have actually picked up one of the other things that they were, right, from that. They don't want to take a person, just test them for COVID, then release them on the street with flu, and then flu starts going rampant, right, instead, right, to do it. So I think a lot of people are, I don't think the PCR test will ever go away, right, from this. And Doc, you can actually comment on that, will go away. But new tests and more rapid tests will be coming out. Do we see a test that's going to be totally dedicated towards home, right, where somebody can administer themselves without having, I know antibody maybe, but on the COVID test, they're saying that a physician or a technician still needs to read it, right, from that. Do you think we'll ever get to where it's done at home?
Yeah, I mean, I think it's two things. One is you want to be sure when you collect the sample, you do it properly. Yeah. So there's some that have been looking at telemedicine assisted collections. And then the report that goes back, I think you're right. I mean, right now you have to have a physician do this. I think the idea is to get the information to the patient as quickly as they can, because if they have COVID, they need to stay home. They need to isolate. They need to do contact tracing, which is actually the responsibility of the lab to the CDC, so that they can figure out who that person has been in contact with. So it's not really just for yourself, but it's for everyone that you've been in contact with. And so there's a process in place that has to get orchestrated once these tests are done. So I think the key to collection at home is to do it properly, to make sure you get a specimen that will be a good test of whether or not you've been infected.
I think one of Cynthia's innovators actually will take and develop an app that actually you can take it with your smartphone and take a picture of the assay or the strip to make sure that you not only get the value, but that it was collected correctly, right, as well. So I've seen Healthy.io does that, and some other companies do that on rapid diagnostics to kind of use the camera, right, and the analytics in the cloud to make sure that sometimes that the data was collected correctly. Do you have any companies like that you're working with, Cynthia?
There's a number of companies that are very active in working with patients who actually are being challenged by sleep, or they're not sleeping well, or they have company out of Colorado, Eversleep, that is providing a lot of measurement for your sleep. And I've read recently about the Italians using robots to go in and clean, using them rather than exposing a human to actual cleanup of these areas, using robots. I think the robots were invented in Denmark, and then they are being used in Italy. And since they've started using robots for cleaning, none of the doctors or nurses have come down with COVID.
Yeah, it's interesting. There's a company in Arizona that does Raman spectroscopy, and they're actually starting to look at how they can do within minutes determine whether a signature for COVID shows up. But then they can also use the same laser to clean, right? The samples as well, which is pretty interesting. The one
UV light is another thing, different lights for cleaning.
Yeah.
Many people are starting to use and look at, and even outfitting the offices, both from an airflow and from the UV light perspective.
It always freaks me out to go by Scottsdale Osborne and see lights and lasers flashing in the rooms, the hotel's room, because they're in or radiating the room, right? Or UV lights to get rid of the germs. We've got a few minutes left on this, but I wanted to ask a couple of questions about where you see this is going. One of the things that, you know, as far as for the future, I think we're learning, right, along the way. When we were making ventilator after ventilator after ventilator, when this is first starting, I think they realized that sometimes the ventilator isn't appropriate, right? Or the level and degree and the pressure was blowing out the lungs, right? It wasn't appropriate that the virus had gone after the lungs. One of the questions on here was about diabetics, that people that are, you know, a type 1 diabetic or brittle diabetic could be 30 times more likely to contract the virus or to suffer consequences because of the virus, right, from that. So we know it's going after the heart, you know, we know it's going after, you know, the pulmonary system from that as well. Where do you think we're going in the fall timeframe? Some people are saying that it could be 5 to 10 times worse than what we just experienced in April and May. Joan, do you want to talk to that first?
I think that anything that we're talking about future tense until we get to herd immunity levels after vaccines are available is pure speculation.
Yeah.
And it also can seed fear in the community. And you get into a scenario where you're almost perceived as crying wolf.
Yep.
And then when you really do need to get that message across, people won't listen. So I'm not sure that those speculations are doing the community any good. I think what we really need to focus on is getting the behaviors that we need now. Eat well, sleep well, wear a mask, wash your hands, sanitize your environment, be respectful and considerate of others. That's what we need to focus on right now, and not multiple predictions from different researchers throwing out different numbers so that when the scientists really do have answers, nobody's going to believe us. And that's a mistake.
Great. That's a good response. So Dr. Smith, your thoughts on that?
Yeah, I mean, I definitely agree with what Joan said. I mean, people are looking at history and assuming that we're going to have a terrible second wave. But talking about innovation, look how quickly everyone has stepped up. They've moved from what they were working on to COVID, taken all this innovation, all the dollars that have been spent on other viruses, other diseases, and really applied it to fighting this disease. And, you know, for us at CURA, we will always look at a multidisciplinary approach. And I think we're seeing that here more than ever, bringing people together, bringing the community from funding, from different innovations, policy, really working globally with data to really try and focus and come up with solutions. And I think we have every chance and every reason to believe that we may not have as severe of a problem in the fall.
Gotcha. And then Cynthia, I wanted to go over to you really quickly on your thoughts, right, about the fall from that as well. And what we can do besides Joan, you talked about wearing masks. What can we do to actually, you know, be preventative and make it and try to get vaccines to us quicker? I mean, that's those two different things again, right? Preventative, but also vaccines, but how we can get innovation to us sooner, right, as well.
Well,
Sorry, I was going to ask you really quick. I'm sorry to interrupt you. The question I was going to ask is, you know, are we, and maybe this is for Dr. Smith too, the acceleration we're seeing in vaccine development, are we going to go back? This is because of the new normal. I have to phrase it this way. Are we going to go back to the way we were before when we developed vaccines? Or have we learned something, how we can get vaccines to market and treatment to market quicker, right, as well, innovation to market quicker? Sorry.
I think that we've learned something and we're not going back. I think that actually it's really remarkable how quickly humans do adapt. And maybe it goes back to Darwin, you know, survival of the most adaptable. And that's what people have done. The policymakers have stepped up. There's been global challenges, but global communication at the same time. And you're talking about incredible changes in the supply chains, airline travel, and there's been a lot of communication, but we still need to do more. You know, there are still so many places there people are not on the internet. We have a great connection tonight, but you know, when you think of a city like Dallas, Texas, that 30% of those households in Dallas with children don't have internet, and it's a cost issue. So communication is going to be more and more important. These wonderful phones that can do so much. And I do agree with you that apps will be coming forth. We may even be using a time where just our breath will tell us a lot about our health.
Yeah, it's interesting that we had initiatives, the broadband initiatives in rural, you know, America to try to go through the, I think it was USDA that actually was funding it, and now the FCC, to try to get more spectrum out to rural locations. But we're now having to do that for education and children, right? They need to have it at home for seniors and people that want to live independently with healthcare as well. So that's one of our future webinars, is talking about the broadband initiative, right? And connecting people as well out there. So, so Dr. Smith, to wrap it up as well, do you think we've changed the way that we develop vaccines for the future?
Yeah, I think there's a couple of things, not just vaccines. I think innovation in general is driving how we're going to deliver healthcare. And it's just so important. We're realizing that health is not just medicine. Health could be an Uber car that takes you to your appointment. It could be food. It could be a refrigerator to keep the insulin or whatever the medication is, you know, under the temperature that it needs to be. And we're starting to look more towards health as at a whole. And, you know, we're looking to take, hospitals are great if you're really sick, but we don't want people to necessarily get health care at the hospital. So telemedicine is an area that I think will continue to be part of how we deliver medicine more toward the home, whether it's remote monitoring, whether it's a doctor's visit from outside the hospital, and any innovation that we're doing. I think we've learned a lot about clinical development and how can we apply that to other diseases, not just vaccines, but we need to get technology to the patients as quickly as possible, safety first, but how do we shorten the time and the dollars that it takes to be sure that safely we can get these innovations to patients. And so I think we'll continue to see change, both from the FDA perspective, from the approval perspective, telemedicine, being able to work cross borders, whether you're licensed, there was an ease of that you could, through telemedicine, work beyond the states that maybe are licensed. And we'll have to see how this all gets applied and how the new normal will be different in how we deliver healthcare in the future.
Yeah, we've talked about that roughly in the past, about reimbursement and licensure and parity and everything that's been kind of wavered, like the 1135 waivers and everything going across state to state and be able to take care of people. That's all been kind of opened up, right, for us. And do we think we're going to go back, you know, is the interesting thing. Most people will say that telehealth had probably an adoption of about 2% back in February timeframe. Today, it probably has an adoption of 70%. So physicians now have gotten used to it. Consumers have now gotten used to it. That's the way they want to embrace people, this way. I mean, you still need the human touch, right, and stuff. But it's probably going to be the way we are going forward, right, as well. So, Joan, what would you like to leave us with when we end this webinar?
I think that the last thing, because this is supposed to be about philanthropy and, you know, the foundations and what the foundations are doing. And we have an economic impact to this health emergency. And one of my biggest concerns is that the small innovative companies are the ones that are not going to be able to access capital during this recession. And in the last recession, we lost innovation. We lost innovators because their company literally ran out of money. And I think that the critical need is not just right now for funding healthcare, but finding ways to continue to finance and fund innovation so that we can be delivering these cures and treatments for COVID-19 and for all of the other diseases that we still have to have a responsibility to find answers for. So I think my closing would be from a philanthropic perspective, remember that just supporting the hospitals right now or just supporting a school right now, we also have to support innovation.
Absolutely. So we're going to wrap up, but Dr. Smith, I really want you to talk just a few seconds about CURA Foundation. You did talk a little bit about policy, but what is your main mission behind the CURA Foundation?
So we really want to improve human health, and we believe that the way to do that is through, taking disparate, really a multifaceted approach. So it's either multidisciplinary, working together. Medicine has become so specialized and so siloed that there's so much to learn from one another. And we've seen that in cancer with immunotherapy, the immunology, teaching the oncologists how to get your immune system to help fight cancer. And that extends into many other areas. So we're really about creating a community, and it's not just about the physician or the researcher, but it is about policy, philanthropy, even religious leaders. How do you bridge the gap so people don't feel like they're choosing between science and faith? How do you bring it all together and make a healthier community, both at the level of the family, the city, the state, the country, and even worldwide? And the only way to do that is to bring people together, to work together on problems, and think a little out of the box, a little innovatively, to be able to come up with solutions that maybe each person on their own couldn't do.
That's great. So we're going to go ahead and wrap up. I want to thank each one of you for joining us tonight. It's interesting. You know, when we talked about, I have a mentor and advisor with us, Dr. Jay Saunders. And I'll ask him, Jay, is it telemedicine? Is it telehealth? Is it digital health? Is it personalized medicine? I mean, what is this? And to him, he said, we've gone far enough with it that now it's just health, right, from that. And that's the way it should be. So I want to thank each one of you for joining this evening. I want to take a minute and thank our distinguished panelists, Cynthia, Ekberg, Shai, and Dr. Robin Smith and Joe Koerber-Walker. For your participation and great insights into care, support, and innovation in the new normal, in healthcare, in our lives. I'm sorry that we weren't able to get to all the questions tonight, but we will post the answers on the life365.health and www.newnormal.buzz website, as well as the recording of tonight's webinar. Please be safe and healthy. Please join us next Wednesday, June 24th at 7 p.m. We may move that to 10 a.m., but we'll let you guys know. With our new normal webinar, because we have somebody coming in from London on the webinar, of lessons learned from the past, insights into our future with noted epidemiologists and virologists. So have a great evening, and thank you for joining us.
Thank you for having us.
Thank you, Kent.
Thanks, Kent.
Be safe.
Thanks, everybody.
Thanks, Robin. Thanks, Joan.
Bye-bye.